首先还是提醒一下线上的会员哈，记得要签到。好，我们在 Google 表单上签到一下就好。OK， 那我们开始今天的那个哈。Dear colleagues of Taiwan Association of Obstetrics and Gynecology, and our distinguished guests, welcome to join the first American-Taiwan Joint Conference. Now, let's welcome the President of TLG, Professor Minza Huang, to open the Congress.
Thanks for the Secretary General, the Dr. Huang Jianbei's introduction. Good morning, the Professor Su Chongxian, Professor Chen Shiyuan, and also the Professor Ying Zhonghe in Taichung, Zheng Yamin in Tainan, and also the Cui Guanghao in Kaohsiung. Okay, and on behalf of TLG, I would like to thank the Professor Mark DeFrancisco and Jenny Corey for coordinator the first AT Joint Conference. It's very honored to be at here for the AT American-Taiwan Joint Conference. Okay, it's the first time the conference between two countries. In the past 10 years, the TLG tried to establish the relationship between ACOG, but I know it's very difficult to have a regular conference between two countries because of the distance. Okay, we invite a lot of the president of the ACOG come to Taiwan for academic exchange in the past, including the James Martin, the Tom Gillis, and also the Mark and the Jenny. Unfortunately, the James Martin passed away last year. We miss him. But the webinar conference may be the option for the future between two countries because of the pandemic of COVID-19. Okay, we invite the speaker come here. It's very difficult to invite a very important speakers to come to Taiwan to speak. But the webinar conference is easier for the future. So it's maybe the first time we establish the AT joint meeting. Then we can have the continue the exchange program in the future. And all of you enjoy the meeting. And also I hope the meeting will succeed in the future between the two countries. Thank you so much. Thank you. And next one, we invite the Professor Mark DeFrancisco. He's also the only fellow of the TLG. He coordinated the meeting in the past 3-4 months. We invite for the opening ceremony. Thank you, Mark.
Great. Thank you very much. Good morning, or it could be good evening, depending upon where you are right now. Greetings to my good friends in TEAG, including President Professor Wang, all the members of the board of TEAG and the organizing committee of this meeting, speakers, and meeting attendees. Hello, and it's wonderful to be together again, even if it's virtual. There is a familiar proverb that even the longest journey begins with the first step. Well, today it's my great honor to be here helping us all take this step together. During my terms as president and past president of the American College of Obstetricians and Gynecologists, I had the good fortune to participate in 2 of your TEAG meetings. I was especially impressed with not only the quality of the educational programming and the inclusion of members of other professional societies internationally, but also with the warmth and the friendliness of my TEAG hosts. I would again like to say thank you for your continued friendship over the years. The meetings I attended included what was called at that time a JKT session, which included speakers from Japan, Korea, and Taiwan. And during some informal conversations that we had enjoyed during those meetings with Dr. Wang, Dr. Kuo, Dr. James Shea, and other TEAG leaders, we discussed how nice it would be if we could add the letter A to that alphabet and have an AT type of meeting in the future. Of course, change like this does not come overnight. It's very difficult, and as Dr. Wang just said, Professor Wang just said, it is difficult and it's very time-consuming. And of course, we know the pandemic has slowed everything down these past couple of years, 2.5 years or so. So a lot of good change has been put on hold. But it appears now the world is getting ready to reopen again. So I think we're getting closer to be able to do this. We've come a long way, at least. So today we're taking the first step of what I hope will be a very long journey together. This is the first joint American-Taiwanese professional education conference in obstetrics and gynecology, and it's my fervent wish that there are many more in the future. Dr. Wong, I want to congratulate you and the TAOG Society on an historic achievement, the first AT joint conference. We are honored to be here, sir, and I want to also thank the speakers, American speakers, who are participating in this also. You are also to be congratulated on navigating very difficult waters during these past 2.5 years and keeping TAOG alive and well in very challenging times. Thank you for allowing me to participate in this program today. Congratulations again on what will be, I'm sure, a wonderful program. And I wish you and TAOG continued great success in the future. 谢谢。
The president of TAOG, Professor Min Zhao Huang, and also the coordinator of this meeting, Mark Francisco. Ladies and gentlemen, this is my great honor to chair this session, particularly with my good friend, Professor Chen from Taiwan University. Today, we have very excellent speakers. Jim, are you on the line? Hello. Okay. Because we have to wait until the 8 o'clock. Before the meeting, may I mention there are 4 meeting sites, including Kaohsiung, Tainan, Taichung, and also the Taipei here. In addition to the in-person participants, we have participants online. Hopefully, this meeting will give everybody a good education program. Everybody will enjoy it for a unforgettable experience on your experience or practice or your knowledge. Okay. The first speaker coming from States, Jim Conray. She's also our good friend. Also the honorary fellow of Taiwan Association of Obstetrics and Gynecology. She graduated from University of California, Davis, with her MD degree. And during 2013 and 2014, he was the president of American College of Obstetricians and Gynecologists, and also the chair of Women's Preventive Service Initiative from 2016 and 2026, and also appointed to the Partnership for Maternal, Newborn, and Child Health, WHO, between 2021 and 2024. And he was appointed to the president of CEO and founder Environment Health Leadership since 2017. Currently, he is the president of Fetal. Her topic for today is global impact of COVID-19. May I invite everybody to give a big hand to welcome Professor Jean Conray.
My thanks to the Taiwan Association of Obstetrics and Gynecology for calling together this important scientific collaboration between the American College of Obstetricians and Gynecologists, TAOG, and the International Federation of Gynecology and Obstetrics. I am going to begin sharing my screen because I'm going to talk about the global impact of COVID-19. Thank you very much, President of TAOG, Dr. Wang, for arranging this great collaboration. And thank you for asking me to discuss COVID-19. 2 years, a little over 2 years since we had our first cases, and it impacted the world so much. I have no conflict of interest to report. And I'm going to start with a history about its global impact and refresh all of our minds about all the different stages we went through, address sexual and reproductive health, describe practice changes, describe vaccinations and obstetric care changes, and then summarize with inequalities, repercussions, resilience, and the reliance that we've seen from the pandemic. And this is the virus that has created havoc in the world for the last over 2 years now. I think it's a picture that we're all very familiar with. But let's look back. In January 2020, China confirmed 3 deaths as a new virus began to spread to cities. Now think back about that time, because that's when we were looking at the TAOG meeting. I think it was going to be in sometime in February, end of February. And I know personally I was making plans on going to the meeting. And I called you all and said, I'm hearing about this virus. Diana Ramos and I were going and started making plans on personal protective gear in case we needed that on our flights. No way did we anticipate what was going to happen in just over a month's time. We had heard about lockdown in Wuhan, China. But if we look back, it was January 18th when there were 3 dead. January 21st is when Taiwan had its first case, and so did the United States. But retrospectively, we know very clearly it was in our countries in December, at least. United States, when we've gone back and done blood samples, seen it in California in December. January 23rd, World Health Organization said this is not a public health emergency of international concern. Then they reversed that decision in January, on January 30th. By February 2020, we were undergoing the preparations for TAOG, and I remember you saying that there was going to be an emergency meeting amongst all of you to decide what to do, and the meeting was canceled. That was the first inkling that the world really was changing. And then on March 11th, a global pandemic was declared and a lockdown. Jump forward just a matter of months, and December 2020, the jab, or in the United States, the shots. We were all able to begin the vaccination series. So in a short time, but now over 2 years and a few months, and we're still facing pandemic choices. Look back about Japan. Remember the cruise ship with 4,000 passengers that docked in Japan, and 4,000 passengers and the crew were quarantined for 2 weeks. And then it was the passengers as they were released. I know very clearly in California, some of the first infections in my community came from passengers that were being released from that cruise ship. That was February 5th, 2020. The cruise ship not being able to let anybody disembark. Then we started looking at shortages. Armed robbers in Hong Kong stole toilet paper, and it sparked panic buying of essential goods across Hong Kong. And I know the joke in the United States was the toilet paper was disappearing. Critical goods were all disappearing. The World Health Organization continued to play down the pandemic fears even as more people died in Italy. But then by the end of February, February 22nd to 28th, the outbreak grew. Iran, Italy, South Korea, travel restrictions increased. Middle East and Europe grappled with the spread. And here's the Basilica in Florence with armed guards and nobody on the streets. By this point, we're looking at late February and into early March. March 7th to March 13th. 20% of all students worldwide are out of school. Countries are closing their borders and declaring states of emergency. Europe became an epicenter with everything that was taking place in Italy, and the United States. We canceled the basketball season. By March 13th, 5,000 people had died. 5,000 people. And we still hadn't declared a pandemic. I came home from Europe just about that time, right around March 17th. California issued a stay-at-home order for all 40 million residents. I think I was on the last flight out from Paris. So California was the first state in the United States to have a lockdown, continued that lockdown, and had a very low occurrence of COVID for the very first part of the pandemic, and then caught up with the rest of the world. United Nations launched a $2 billion humanitarian response, but World Health Organization said we were in serious trouble because we had shortages of medical supplies. And I don't think even at that point, that was March 13th, they had any idea that the supplies were going to become as short as they were. But let's look ahead. 2022, the 13th of March, we had 455 million cases of COVID and 6 million deaths. 56 countries alone with 1 million cases. But then Tonga, an island, isolated, closed down early, had contained COVID to 1 case until January of this year. And then they opened up because of a sporting event, and now there are over 2,000 cases. The first COVID vaccine was issued on December 8th, and by March 17th of 2022, 11 billion vaccine doses have been administered. So remarkable progress against a pandemic that I think people had predicted we could see something like this, but nobody imagined it. So let's look at our maternal health point of view. And I'm going to do a little bit of a retrospective here. March 19th, FIGO issued a statement. FIGO is closely monitoring the COVID-19 pandemic. We will post timely information that supports global women's health in this exceptional time that is challenging the resources of our providers around the world. By this point, we were hearing how serious the conditions were in Italy, and began having it every other week, a bi-weekly meeting with leaders around the world to hear right then how every country was responding. On March 25th, we were comparing SARS-CoV, MERS, and CoV-2. Looking back to 2009, pregnant women accounted for 1% of the H1N1 virus infections, yet 5% of all the deaths. So right then we realized that we had the possibility for a pandemic that was going to adversely impact women. But the first results, the first information coming out of China and out of Italy downplayed that. We just did not see the adverse outcomes in the very early patients. One of the first things we were asked is, what guidance do you have about women trying to conceive? We said early pregnancy guidance with very little information about a virus that is not novel. This next year is one of uncertainty and optimism. Optimism because in the few pregnancy cases we've seen, it's not been accompanied by adverse maternal and fetal outcomes. Now I'll share how off base we were there. And uncertainty because we've still got 6 months to a year before we see the effects and can truly be able to guide women. Clearly, by summer of 2020, we had enough information to share with women and all healthcare providers about the serious outcomes of pregnancy. Vigo stated at that time, though, again, this is April 2020, that pregnant women require special attention in relation to prevention, diagnosis, and management, because up until this time, all of our observations were based on 5 small series and only 56 women. So we said we just cannot predict the direction that this pandemic is going to take. Why are pregnant women so vulnerable? Well, the area that we're all very familiar with is the immune response. We know how much the fetus is protected by a woman's lack of an effective immune response with T helper cell dominance that protects the fetus. So it leaves women vulnerable, especially to a viral infection. And then pulmonary changes. Mothers are more susceptible to infections. They've got reduced lung capacity. So we knew at that point that it was a respiratory infection. So women were vulnerable simply because of their immune response and then because of their respiratory status. So we appreciated then the extreme vulnerability. But looking back for Taiwan, it was September 2021 before you had the first pregnant woman with COVID-19, the first case report. The woman visited the emergency room, had complaints of abdominal pain and decreased fetal movement. She did well. Her infant did well. She delivered by cesarean section. And I'll describe some of the placentitis research that's taking place right now. But in some ways, the woman with decreased fetal movement and being delivered immediately may have been one of the, certainly a reassuring outcome for the physicians and for the patient. In the American Journal of Obstetrics and Gynecology in May 2020, there was a survey of only 41 pregnancies. So again, this is early on in the pandemic. Some of the research was coming out of the Eastern United States, where they were especially hit hard. We had research coming out of New York and Boston. Here we had 41 pregnancies, so a small series. Preterm birth was the most common adverse pregnancy finding, but there were higher rates of pre-eclampsia, cesarean section, and perinatal deaths. This time I received a phone call from a colleague saying, you know, a family medicine doc who was treating adults and pregnant women, and her saying, we're seeing a really high rate of thromboembolic disease. Are you seeing that in pregnant women? And at that point we said, no, it hadn't shown up. But certainly looking at all the varied types of complications, it is a concern. And then in a journal article that was released recently, just in January 2022, looking at England alone, they called it a diverse cohort, 218 pregnancies. They said, again, found a significant effect of COVID-19 on preterm birth, but it was confined to symptomatic women, which is an important distinction from some of the other research studies. And they did not see growth restriction or preeclampsia. So almost a very, if a woman gets very sick, it's going to lead to some adverse sequelae. And if she's not very sick, she probably is going to do fairly well. But it was starting in, I would say, May of 2020, the first announcement came out from the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine and our own Center for Disease Control that looked at the outcomes that they were seeing from the very high incidence of COVID in the Eastern United States. And the recommendations or the observations were that pregnancy is independently associated with a 3-fold increased risk for intensive care unit admissions, a 2.4-fold increased risk for needing ECMO, extracorporeal membrane oxygenation, a 1.7-fold increased risk of death because of COVID. So we're looking at high risks of major maternal complications and severe infections that were associated with hypertensive disorders and preterm delivery. So the message about preterm delivery is clear. Again, this is because a woman who is very ill, coming in at 32, 34 weeks, she gets delivered. So the preterm delivery makes sense to try and help the respiratory compromise of these patients. But what we're seeing in the United States that was different from in England was the association with hypertensive disorders and other complications. Then the CDC went on and pointed out that pregnant women with comorbidities, so a body mass index over 35, any cardiac disease, diabetes, age over 35, particularly high risk of adverse maternal outcomes. And that message has been consistent, and the findings consistent from that point through every variant that we've seen, unless a woman is vaccinated. The pregnant women that we're still seeing dying in the United States are not vaccinated. For our vaccinated population, they may be sick, they may be admitted to the hospital, but the survival has been good. So the vaccine was a game changer. Now, I mentioned the SARS-CoV-2 COVID placentitis. I was just at a meeting in Ireland a couple of weeks ago and listened to a presentation by Dr. Brendan Fitzgerald, who is a histopathologist and a perinatal pathologist. His entire career is spent looking at placentas. He gets the placentas from, I believe, almost all of Ireland are sent to him to review, and his findings have been significant. They published these in just this year, SARS-CoV-2 placentitis, an uncommon complication of maternal COVID-19. He published this with a series of OBGYNs and the research that they were looking at, and said, although it is uncommon, they've seen it only in 11 of 235 placentas. He is looking at every single placenta for every woman who delivers. So about 5% of the placentas, but the findings were significant. The photographs I'm showing here is a woman who had an emergency cesarean section for reduced fetal movement, much like the woman from Taiwan, and a non-reassuring fetal heart monitoring strip. She was COVID positive, but she wasn't severely symptomatic. So what he is seeing is this placentitis is an uncommon but distinctive complication of maternal COVID-19 infection, and has the potential to cause significant placental injury resulting in fetal compromise. And they are seeing it even in women who the mom is not severely compromised. And I think that's the most worrisome finding. ACOG is still looking at this. ACOG has not seen the same distribution, but I will say the expertise of the pathologists is probably more varied, because here in Ireland, every placenta is being sent to one physician to review all of the findings. And I think when you've got somebody who's a placental specialist, it truly makes a difference. Now, I talked about a game changer. The patients that we're seeing now are surviving. Think back about those early days, and I think everybody can relate to what was happening. Our guidance early on was one of fear, because we knew patients were ill. We knew the healthcare providers initially were being told that they didn't need much in the way of personal protective devices. How much do they need masks and gear? So if you think back at the initial stages of the infection, physicians were worried, nurses, midwives, were all worried about the circumstances and the care that they were giving, but they weren't allowed to use the personal protective gear. There truly was not enough to go around, and it created so much angst. That angst has disappeared and now probably converted to exhaustion with this vaccine. The coronavirus COVID-19 vaccinations, 64% of the world population has received at least one dose of the vaccine. 11 billion doses have been administered globally, and 17 million are administered every single day. But only 14% of people in low-income countries have received at least one dose. So we have not succeeded in getting the vaccine widely distributed, but we do know it's been extremely effective. We look at the vaccine dose administration per 100 people. This is from March 17th, 2022, and deep green shows very high penetration, and down into the yellow is low penetration. And right away we can look at the continent of Africa and see, even with attempts to get the vaccine there, the health system infrastructure has just failed. There have been vaccines promised and not delivered, vaccines delivered to central sources and not able to be distributed, whereas most of the rest of the globe, there's been a fairly adequate response with patches here and there. In Taiwan, you've done a phenomenal job. The Taiwan Center for Disease Control publishes this on a daily basis. So I took a photograph from March 17th. 82% of the population has received at least one dose, and about 50% of the population is fully vaccinated and has a booster. So fully vaccinated is 3/4 of your entire population. So you're doing extremely well. So Taiwan did very well in isolating, in preventing the infection from spreading. I think it's a testimony to how strong the message was. And I appreciate so much when Teag contacted ACOG and said, can we give you personal protective gear? You need it. And quite honestly, ACOG couldn't figure out a mechanism to get it out to the doctors in the field, because it was not that we didn't need it. It was, I think, more the steps on how to take your generous offer. What were FIGO recommendations? Our Safe Motherhood Committee, very early on, shortly after the jab was released in December, we have had a webinar and a debate about the vaccine. The final conclusion was that FIGO considers that there are no risks, actual or theoretical, that would outweigh the potential benefits of vaccination for pregnant women. We support offering COVID-19 vaccination to pregnant patients. Given direct benefits of breastfeeding, the COVID-19 vaccine can be offered with counseling. So our first recommendations were offered. We then fine-tuned those and said, we recommend. We had a series of discussions between our Safe Motherhood Committee and our Ethics Committee. And the Ethics Committee said, we need to step back and look at this as an ethical discussion. We have not been allowed to have women, pregnant patients, in any of this research. The type of research we're doing is happenstance. You have people who get the vaccine and then find out that they are pregnant. So we had registries that came up. We had mostly healthcare providers say, I don't care about any unknown risk. I want the vaccine. So all of those individuals were tracked. What the Ethics Committee said is, we know how serious these infections are. We know the adverse outcomes in pregnant patients. We know what happens when someone is not vaccinated. So knowing all of that, the risk of not being vaccinated is much higher than the risk of being vaccinated. Women need to be vaccinated. A mother who doesn't survive pregnancy is not going to have an infant survive. So we needed to shift our way of looking. And at that point, I would say it was a slow move around the world for different groups to start changing their message, if you will. The ACOG and the Society for Maternal Fetal Medicine ultimately came out with a very strong decision. Again, their first decision was about offering the vaccine, but then they changed those recommendations as more and more research came out showing the adverse outcomes. Society for Maternal Fetal Medicine recommends, and that word recommends is important, that pregnant, postpartum, and lactating people and those considering pregnancy receive the COVID-19 vaccination. Vaccination is the best method to reduce maternal and fetal complications of SARS-CoV-2. Counseling to support the recommendation for vaccination should include available data on vaccine efficacy, as well as data on vaccine safety during pregnancy and lactation. Provider counseling has been shown to have a significant positive impact on patient vaccination. So these messages were released probably about 8 months after the vaccine became available, and then continue to be updated as more and more research comes out. I think what is particularly telling is that the guidelines for COVID vaccination in pregnant women in the United States, released on July 30th, 2021, ACOG and SMFM recommend that all pregnant individuals be vaccinated. So again, it's a much stronger statement. Not offered, recommend that they be vaccinated. COVID-19 vaccines is recommended for all lactating individuals, similar to non-lactating individuals. So whether you're breastfeeding, no matter what your condition is, get vaccinated. Individuals considering a COVID-19 vaccine should have access to available information about the safety and efficacy. And number 4 is particularly important. While a conversation with a clinician may be helpful, it should not be required prior to vaccination. So initially, there were pharmacies were turning pregnant patients away, saying, go talk with your doctor. And CDC and ACOG and SMFM came out and said, no. Although it's nice to have a conversation, you can see a clinician, that is not a necessary prerequisite. It may cause unnecessary barriers to access. If a woman is ready for a vaccine, vaccinate her. And similar to non-pregnant peers, vaccination of pregnant individuals with vaccine may occur in any setting where it's authorized. So you don't need to send a patient to her doctor's office. You don't need to say, go to the hospital. Any pharmacy where anybody is getting vaccinated should be able to vaccinate a pregnant patient. And again, pregnancy testing is not a requirement before COVID-19 vaccine. So every point we could make came out very strong. So this was by July 30th, 2021. The message became very strong. And since then, it has been very consistent. Now, it was 2 months after this that FIGO and the Royal College were part of a roundtable discussion on vaccinations. And we could see the entire range of vaccination recommendations. So at that point, Australia wasn't even recommending the vaccination. The Royal College was at that point saying offer, and we have ACOG and FIGO saying recommend. So we saw even then physician organizations vacillating in how strong it was. After that series of discussions, though, a number of countries went back to their ministers of health and said, we need to put women as a priority. So I think sharing information while a pandemic is going on is very valuable because we saw changes in policies that occurred. What about the uptake of the vaccine by pregnant women in the United States? So this was March 14th, 2022. Over 200,000 pregnant people have reported being vaccinated. And we have a pregnancy registry of 19,000 people. Again, no adverse reactions out of the ordinary. The findings were comparable to anybody who was getting vaccinated. So no different for a pregnant individual than a non-pregnant individual. In June of 2021, we looked at preliminary findings of COVID-19 vaccine safety. And again, no concerns there. 16% of pregnant women had received over 1 dose by the time of this study. The vaccination rate was lowest among Hispanic patients and non-Hispanic Black women and in younger women. And it was highest among Asian women, about 25%, and women aged 35 to 40, 35 to 50, about 23%. And I will tell you, I searched the literature trying to find vaccination rates for pregnant patients, and it is extremely difficult to find that information. Other than this, the small registries we've got, I know that there are countries that have registries. I wasn't able to find very easily any data showing, pulling out pregnant patients from all others. But we do know that we have to look at ethics for vaccines, epidemics, and new technologies. We know that we have to look at the ethical inclusion of pregnant women in epidemic vaccines. If we are truly going to be prepared for changes in in COVID, or in anticipating another pandemic, we have to be prepared to have women and pregnant patients, pregnant women, in our studies if we're going to have an adequate response. Vaccine coverage has been increasing overall. By August 2021, about 22% of women giving birth had received at least one dose. This increased to 32% by September, 41% in October, almost doubling in 2 months. So of women who gave birth in October 2021, about 30% had had 2 vaccines. So again, concerted effort on messaging makes a difference. Having a healthcare provider discuss makes a difference. With the CDC, the Centers for Disease Control in the United States, COVID-19 vaccination is recommended for people who are pregnant, breastfeeding, trying to get pregnant, or might become pregnant. Basically, everybody should be vaccinated. The new data, we started seeing the news. Here's the Taiwan news from April 2021. New data reassuring for COVID-19 vaccination in pregnancy. The impact of COVID in pregnancy, part 2, vaccination to pregnant women. Again, a research study out of Taipei. All the research emphasized an urgent need of national or international recommendations and guidelines to optimize prevention and management strategies for COVID-19 in pregnancy. Again, the conclusion was vaccinate. Now, why have we seen such barriers to the success of vaccination program for pregnant women? It certainly has been a concern in the United States across the board for vaccines in general. We've had a strong campaign for tetanus, diphtheria, and pertussis, but we saw even more hurdles when it came to COVID vaccinations. There were disinformation campaigns. 54% of adults believed misinformation, absolutely false information. More than half the population believed it. There's a politicization of vaccines, and I'll get into that. There's an intrinsic vaccine hesitancy that we had seen from Tdap. About 1 in 4 people surveyed are unsure whether you can get COVID-19 from a vaccine. All they had to hear was RNA, DNA, and the NAs, and it made them think that they were changing their genetic makeup and could get COVID from a vaccine. 1 in 5 believe or are unsure whether those who already have had COVID should get vaccinated or not. 1 in 5 were uncertain whether the vaccines contained fetal cells. Again, misinformation. 1 in 5 were uncertain whether vaccines would cause infertility, and 1 in 5 were uncertain whether it changed the intrinsic DNA. So all of the information that's out there in the on the internet, people absorbed, they listened, and it created enough doubt that today the people who are still dying in the hospitals are these unvaccinated individuals who chose to listen to misinformation. Pregnant people are still not getting vaccinated against COVID. Again, Science magazine showing that with Omicron surge is still putting carriers and babies at risk because the misinformation has muddled the messaging and they are not getting vaccinated. And those are the individuals who are sick and dying. Again, here, according to data from the United States Centers for Disease Control and Prevention, as of January 1st, over 40% of pregnant people in the United States between 18 and 49 were fully vaccinated prior to pregnancy or during pregnancy, compared with 66% of the general population. For Black pregnant patients, we see even more vaccine hesitancy. We see a basic distrust of our healthcare system, and we've caused that. The figure plummets to only 1 in 4 pregnant people being vaccinated. But I also said there's a politicization of vaccines. Now, this is a graph from 2021, but if you look on the left, it's the Republicans, and if you look on the right, it's Democrats. I guess I have that switched in how I should have presented it. Isn't it true? But basically, about 54% of Republicans at that time had been vaccinated versus 88% of Democrats. And if you looked at the wait and see and all of that, 23% of Republicans said under no circumstances would they get a vaccine. And that number in Democrats was only about 2%. So right back in 2021, as we were trying to push the vaccine and save lives, it was this basic difference with the politicization of a vaccine that has harmed our country and many countries very effectively. There was also wait and see mentality. 4 in 10 of those who said they weren't vaccinated wanted to wait and see. So again, 2021, did they know that the Omicron variant was going to happen? Did we know that the next variants were going to come? No, they wanted to wait and see. And that wait and see meant that they came into the next variants and the next variants. And that's when, again, we saw these upticks in death. So they wanted to wait more than a year. Again, those are the individuals who are dying. And the latest safety data, again, this is put out by the European Medicine Agency in 2022. Latest safety data provides reassurance about the use of messenger RNA vaccines during pregnancy. So all the reassurance that we can give our patients is there. We just haven't been successful. Now, I alluded to some of the problems that we saw at the start of the pandemic, and that makes me talk about safe and respectful care. FIGO and member societies should engage in international rights-based advocacy to make a difference at the country level. A fundamental component of quality maternal and newborn care is access to care that is safe, inclusive, and respectful, and enables women to have dignity and control. One of the problems, again, this is hindsight, this is looking back as the pandemic started and the fear that was rampant. The fear that healthcare providers were going to get infected and be asymptomatic and bring those infections home to their family and kill their loved ones was real. They were afraid that they would cause harm in their homes. And because of that, we saw patients being separated from family. We saw husbands not being able to be in the delivery room with a wife or a spouse or a partner, significant other. We saw all types of separation. We can look back now and judge everybody in a negative fashion and say how awful we were. I would actually ask people to kindly learn from where we were in the past and look at how we should do things differently in the future. But I know there was fear. I know that people did not have adequate personal protective gear. And I know there was fear for family and loved ones. So you compound all of that, our judgment was impacted by that. So what can we do? We can apologize. We can say we were too strict and that we've learned. And I think we look at that as the basis of respectful care. When FIGO put together our strategic plan and created all of our committee structure, at the center of all of our FIGO work is respectful care. And I think that's all we're saying here, that we need to make sure that quality maternal and newborn care is safe, inclusive, and respectful. In the pandemic, we operated out of fear, without science to direct our decisions. Healthcare practitioners used to saving lives were unable to save lives, and they had a fear. The end result were decisions that were not family or patient-friendly. So again, as I said, let's use that retrospective analysis and understand the balance between fear and safety. I said I wanted to talk a little bit about sexual and reproductive rights. We've got the United Nations COVID Impact on Women Summary, which is an important analysis of what happened. So recall, as COVID hit and countries shut down so that Individuals weren't able to get into hospitals, they weren't able to get routine medical care, and even urgent and emergent care was blocked. We had a survey performed by a FIGO team, how the coronavirus disease 2019 pandemic impacted sexual and reproductive health and rights, led by Christina Gemzell-Danielson, who is chair of our Women Facing Crisis Committee. 10% decrease in services led to 49 million women with inadequate healthcare coverage, 15 million unintended pregnancies, and structural issues in the pandemic because of lack of supplies and equipment, staff that were diverted to other types of care. Women were literally told that pregnancy care was not an urgent or emergent need. Miscarriages were not an urgent or emergent need, and abortions were not an urgent or emergent need. So the ripple effect of COVID pandemic, it was more likely to impact the underserved and our adolescent populations in particular. And let's look at a few other areas. Violence against women. 243 million women and girls ages 15 to 49 experienced sexual and or physical violence by an intimate partner before the pandemic. But with the pandemic, we saw increased incidents of violence against women, domestic violence intensified, and exacerbating factors were security and finances at home, cramped living conditions, isolated with an abuser, restricted movements, and deserted public spaces. So before the pandemic, women were at risk. With the pandemic, it increased even more. Before the pandemic, less than 40% of women who experienced violence reported the crimes or sought help. Since the lockdown, domestic violence reports increased. 33% in Singapore, 30% in Cyprus, 30% increase in France, and almost 30%, 25% in Argentina. So there was an increase in reporting taking place. Again, the women were with their abusers in close proximity. What about women's health? 810 women die every day from preventable causes related to pregnancy and childbirth. 3 billion people lacked basic hand washing facilities. Yet we were telling everybody, wash your hand. 500 million women and girls globally lacked adequate hygiene, menstrual hygiene, and unpaid care and domestics. We know that women did nearly 3 times as much unpaid care and domestic work as men. Since the pandemic, the number of factors have added to this. School closures, stretched healthcare systems. We literally saw nurses who created nursing pools. Who was going to be able to go to work that day, and somebody would drop their children off at one of the other nurses' homes just so that they could get into the hospital and work and take care of their patients, but somebody was able to take care of their children. Moms have to work, and they balanced at home. And we saw that affecting women much more than men. A chart here showing the divisions of labor and unpaid domestic work. You can see here the bulk of that falls under a woman's area that she has to be conducting. And healthcare workers. Global health and social workers, 70% are women. Leaders in the healthcare sector, only 30%. The COVID-19 infections in healthcare workers, predominantly women, when we looked at Spain and Italy. So what do we say? Reliance, women count on access, integrity, and availability. So what can we provide for our member societies? First, we led through COVID with our webinar series, our website information, our partnerships, our member society collaboration, and our FIGO statements. You can rely on FIGO to come through. We created the webinars on COVID resources, on elective surgery, on cervical cancer challenges with the pandemic, and a call to action on COVID-19. Health, rights, and well-being of women and girls, global, equitable, and inalienable statements. And COVID during pregnancy just a couple of weeks ago, our update about what's happening. The 17th of March, we had 2,000 people attend our webinar. We need to build resilience. how to make sure that women are not left behind as a result of COVID-19. We have to ensure access to equal technology, increase women's access to digital financial services, lessen the burden of unpaid care, enable them to fully function in the government, and invest in sex disaggregated data. We don't have data, we don't know what's happening. So FIGO's vision is that women of the world achieve the highest possible standards of physical, mental, reproductive, and sexual health and well-being throughout their lives. When we invest in women, we invest in all of our futures. Thank you so much for TEOG, because you invest in your members, in your patients, and clearly in your society. I invite all of you to come to our FIGO World Congress in October 2023. Join me in Paris. Thank you. I appreciate very much being part of this Congress. Thank you so very much for inviting me.
Hello, Jim. How are you?
Hello, Dr. Sue. So good to see you.
Nice to see you again. Now, due to time limitation, I extend 5 minutes for Q&A. Please shorten your comment and question. Before you ask a question or comment, please specify yourself and use the microphone beside you. Now open for discussion from the floor. Any comment or question? Jim, may I give a question for you? Regarding the safety and respect for care for patient,
Yes.
It can be a conflict between the interest of doctor or health provider and the patients. Because when take care of the patient, you want to spend more time or take more chance to care patient. It might get infected. That is risky.
Yeah.
Bring this risk to their families and lives. And will you talk more on this and how to balance this conflict?
That is probably the most important question, because I really believe we forgot. Here we're 2.5 years out from the start of the pandemic, 2 years and a few months, and we forgot how awful it was at the very beginning, where we were worried about bringing infections home to family, and then we would find patients' families lying about their COVID status. So it really was a conflict between providers and patients. And because of that, we made some very difficult decisions. I think what we learned from it is that we need much more honesty and being upfront with everybody that we don't have all the answers. We are working with fear, and be upfront. I have a family at home I'm trying to protect. I need to do what is best for you and for my family and for the staff on labor and delivery. And I think sometimes we're afraid to have those difficult conversations, but it really did, we're so far into this, we've forgotten what was driving all of those decisions in the early parts of the COVID pandemic.
Okay, thank you. Any?
Thank you.
Yes, please. Please use the microphone beside you.
Hi, Jenny, I send you a smart lecture. Because in the past, my opinion, my patient come here in early, where we check the fetal period coming or not. But
Can you repeat?
sorry.
Please,
Thank you. Thank you,
Please.
Jenny, calling your lecture. Your great lecture, smarter. It changed me because I have a patient come in my clinic. We will check first pregnancy test, fetal pregnancy or not, because I'm afraid your abortion, because vaccine COVID-19 injection maybe cause the threatened abortion. So I see your actually, usually the pregnancy test should not be a requirement prior to the receive any UA approved 19 vaccine. So
Yes, very good. Not needed at all. Not needed at all. You can reassure patients that there is no increased risk that we've seen in any way with the vaccine. So no need for a pregnancy test. No need. It's nice to counsel. It's good to have an upfront discussion with patients, but just say, I know the risks are so great to you. If you don't have this vaccine, please get it.
thank you. Thank you.
Thank you very much. That's a guideline from the society. No need to pregnancy test before vaccination, right?
Right.
Yeah, okay. Due to time limitation, it's just short, please, and specify yourself before.
I think that a lot of questions that we have over here is because we were using AZ vaccines on pregnant patients during the pandemic at the beginning. I think that we have started using Moderna or mRNA the past about a year. So I think all the concerns concerning your menstrual cycle and early pregnancy, the causes of missed abortion, could it be because we're using AZ vaccines?
You know, honestly, there is a registry that it has had global input, and that registry is from OB/GYN societies all around the world, and we've not yet seen any adverse outcomes from any of the vaccines. So to date, it's been very, very reassuring regardless. And one of the first publications from the entire world registry will be coming out in just a matter of months. But that group continues to meet every 2 weeks. We have literally been meeting every 2 weeks since April 2020 and discussing findings, discussing everything, and no one is seeing any problems.
Is that okay? Okay, from the VSIF registration, there has been 1,900 registration. There has been no complication reported. That's from Jim's data, right? From your data.
Ah, good. Okay.
Okay. Okay. Same time limitation.
Okay.
I'm sorry to close this interesting topic. Thank you, Jim. Please
Thank
give
you
a big
to
hand.
my favorite society.
Okay. Please give a big hand to Jim.
Thank you.
Now, go to the second speaker, Ted, Professor Ted Anderson from States. He graduated from Vanderbilt University School of Medicine, Nashville, Tennessee, for his MD degree. In 2019 to 2020, he was the president of board director of ACOG, and also the chair of ACOG governance committee since 2020. He currently is the Betty and Lonnie Burnett Professor of Obstetrics and Gynecology, also the Vice Chair for Clinical Operations, Department of Obstetrics and Gynecology, Director of Region of Gynecology, Director of Gynecological Surgery of Hospital Pre-Operative Services, Associate Director, Minimum Invasive Surgery Fellowship, and also Executive Medical Director, Women Health Services, Vanderbilt Medical Center. His topic is laparoscopy surgery in the pregnant woman with non-obstetric indications. Please allow us to give a big hand to welcome Ted Anderson.
Hello, this is Ted Anderson, the past president of the American College of Obstetricians and Gynecologists. I am delivering this presentation from my office at Vanderbilt in Nashville, Tennessee. I apologize that I'm not able to be there in person for this conference, but I'm delighted to be able to join electronically. Today, I want to talk about surgical interventions in pregnant patients for non-obstetric indications, particularly by laparoscopic surgery. This has been becoming increasingly important because of increases in our ability to diagnose problems in pregnant patients, as well as our ability to intervene with minimally invasive techniques. Surgery unrelated to pregnancy is reported in about 2% of pregnant women. In fact, about 1 in 500 pregnant women will have some sort of abdominal procedure during the course of their pregnancy. The bulk of these are, of course, abdominal appendectomy or cholecystectomy or some sort of adnexal surgery, and the bulk, of course, is done laparoscopically today. Historically, there's been a hesitation to operate during pregnancy because of perceived risk of anesthesia, including pregnancy loss or preterm labor, or the risk of low birth weight or neonatal death. However, this has only really been studied recently, since about 1970, and it turns out that the surgical and fetal risk studies began in the 1970s, and the route of surgery, abdominal versus laparoscopic, really only emerged in the 1990s or earlier into the 2000s. In a very large study of over 6 million patients, it was determined that the incidence of non-obstetric surgery is only about 1 to 2% of pregnant patients. We want to look at a couple of risk-specific factors, and the first of those is what we call attributable risk. That is, what is the difference in risk of certain events occurring in mothers undergoing surgery versus their baseline risk? And I have listed in this chart the baseline risk of certain events such as miscarriage or stillbirth, preterm delivery, cesarean section, etc. If you look at the attributable risk, you can see that that is actually very, very low. So the problem of surgery during pregnancy adds very, very little to the problems associated with a natural occurrence during pregnancy. And in fact, if you look at the number of procedures that are needed to be performed to significantly increase the incidence of anything associated with hospitalization, stillbirth, or preterm delivery, you can see that it really requires a large number of operations before you see any significant increased risk to the patient. In fact, there's only one additional maternal death in about 7,000 or 8,000 operations during pregnancy. So it's really very safe, and I want to show you some of the data behind that. Of course, the relative risk of pregnancy-related surgery does increase with gestational age, and there's a 20% higher risk for preterm delivery or cesarean section if surgery is done in the 3rd trimester as opposed to the 1st trimester. Laparoscopy really became integrated into OBGYN in the 1990s, and there are many benefits of laparoscopy over laparotomy, including shorter operative times, shorter length of stay, less trauma and less pain, less analgesia requirement, less blood loss, decreased infections, and more rapid recovery, and certain other risks such as deep vein thrombosis occur with rapid ambulation. The question then becomes, do these same benefits apply to the pregnant patient? Well, there have been arguments that laparoscopic surgery was contraindicated during pregnancy because of concerns for injury to the uterus or concerns for compromise to fetal perfusion because of the increased abdominal pressure and because of the positioning required for laparoscopic surgery. However, with experience, we now know that laparoscopy has become the preferred treatment for many surgical disease, even in pregnant patients. There was a large study in Denmark of almost 2 million pregnancies over the course of 1996 to 2015, with 108,000 operations in 117 pregnancies. The general trend has been favoring laparoscopy over laparotomy. In fact, you can see from the course of time from 1996 until 2015 there was an increase in the prevalence of surgery during pregnancy and an increase in the number of procedures that were done laparoscopically, whether that was for gynecologic or non-gynecologic surgery during pregnancy. If you look specifically at appendectomy, you can see that there is an increase in the incidence of laparoscopic appendectomies performed, and the bulk of these in the first and second trimester. Now, when we talk about laparoscopic surgery in pregnant patients, there are a few considerations that we need to make. First, we have to think about the physiology of anesthesia and how that might impact the patient. We need to think about the physiology of pregnancy and what characteristics we need to consider and what impact surgery might have on those characteristics. Finally, we need to think about the physiology of laparoscopy. That is, what are the unique features of laparoscopic surgery that might impact outcomes of that surgery in the pregnant patient? And then, of course, we need to think about the disease process itself and how surgical intervention is necessary or what impact that has on pregnancy. First of all, with anesthetic agents, if we look at the common agents that are used for general anesthesia, these really do not produce any sort of teratogenic effects in humans. So they are not known to cause genetic malformations or congenital birth defects. Placental transfer of these blocking agents used for general anesthesia is actually quite minimal and should have no impact on the fetus. Nitrous oxide is associated with some theoretical concern because of its inhibition of methionine synthetase activity and potential effects on DNA. But this has not really been demonstrated in humans and the developing fetus in over 70,000 cases. So it's more of a theoretical risk than an actual risk. So the choice of anesthetic agents to be used should be based on standard anesthetic considerations, regardless of whether that patient is pregnant or not. A more critical concern is the passage of anesthetic agents across the placenta. There really is rapid passage of most agents across the placenta and a potential for severe neonatal depression if delivery should occur during the maternal surgery or immediately thereafter. So therefore, we have to consider the potential impact for the need for delivery at the time of surgery. If we look at placental physiology and pregnant physiology, a couple of key factors is that there is an increase in maternal blood volume and a decrease in intravascular colloid pressure. There is a decrease in systemic vascular resistance and an increased cardiac output with increases in maternal heart rate. The minute ventilation increases, as does the expiratory reserve, with decreases of almost 40%. The oxygen demand obviously increases during pregnancy. So we have to consider these different effects of pregnancy when we're considering surgery. If we look at the impact of anesthesia, we can see that certainly we would use a 15-degree left tilt after 18 weeks to prevent compression effects of the vena cava. We would use standard physiologic monitoring. There is no specific fetal monitoring that is required during pregnancy. And certainly an arterial line is not necessary, but could be indicated depending on the specific patient comorbidities, such as obesity or heart disease. No routine intraoperative fetal monitoring is required. One important thing is we need to maintain adequate maternal blood pressure. This is the most important determinant of placental perfusion. So consider the use of vasopressors if the blood pressure drops more than 20%, using ephedrine or phenylephrine as the drugs of choice. We would use IV induction rather than inhalation induction, and mechanical ventilation to match normal respiratory alkalosis of pregnancy is critical, and you must maintain end-tidal CO2 percentages. If you look at the effect of laparoscopy, you can see that with abdominal insufflation for laparoscopy, there's a decreased preload, and therefore you get some inferior vena cava compression. And this results in increased intra-abdominal pressure the gravid uterus causes some compression on the vena cava, resulting in decreased blood pressure, stroke volume, and cardiac output. However, when you look at the effects of Trendelenburg positioning, it actually negates those negative effects. It actually increases preload and venous return and increases return to gravidity, increasing the mean arterial pressure and the cardiac output and increasing systemic vascular resistance. So a lot of the effects that we see from insufflation of the abdomen for laparoscopy are reversed using Trendelenburg positioning. Some of the considerations is that the diaphragm is displaced upward, which tends to cause some hypoxia with decreased functional pulmonary reserve and increased peak airway pressure, with a risk of increased end-tidal CO2. So when you're accommodating for laparoscopic techniques, we would use a left upper quadrant entry into the abdomen for laparoscopy to visualize around the gravid uterus. We would decrease our insufflation pressure that we would use to extend the abdomen to give us room to operate, and minimize Trendelenburg positioning and use a left lateral tilt to normalize a lot of the cardiovascular physiologic changes. Hand-assisted laparoscopy can certainly improve manipulation around the uterus and minimize the need for electrosurgical complications. But most importantly, it's the skill of the surgeon and the team. The person who is undertaking laparoscopic surgery during pregnancy really needs to be very skilled at laparoscopy. And you should really know your skill and know your limitations before you undertake this. The American College of Obstetricians and Gynecologists has come out with a statement on non-obstetric surgery during pregnancy, and in that advice, they have indicated that there is no evidence that in utero exposure to anesthetics or sedatives really has any adverse effect on the fetus. So therefore, pregnant women should not be denied necessary surgery regardless of what trimester it is occurring. We do screen for thromboembolism risk and provide appropriate prophylaxis just as we would with any other surgery. And given the risk of preterm birth, certainly consider corticosteroids if the fetus is at the age of viability, and consent the patient for a possible emergent cesarean section should that be necessary. The greatest risk to pregnant patients for indicated surgery of non-obstetric indication is delay. There is a physician delay of surgery because of the diagnostic challenges associated with pregnancy, trying to determine what is actually going on and if surgery is necessary. And there's a general hesitation to order some of the testing that might be necessary, particularly those things that might deliver radiation. Patients have their own source of delay for fear of preterm birth or fetal harm and fear of complications during surgery. The end result is often surgery is delayed in pregnant patients, and the disease process is more likely to be more advanced, and therefore the patient is more likely to have to undergo emergent surgery rather than surgery in a controlled environment. The most common non-obstetric problems for surgical indications during pregnancy include appendicitis, which is the most common, about 1 out of 500 or 1 out of 1,000. Cholecystitis, which is the second most common problem in pregnant patients, 1 out of 2,000 or 2,500. And then adnexal masses, which is the most common problem, but not the most common operation. This occurs in about 2% of pregnancies, only which a small percentage are actually malignant. The vast majority of these cysts and adnexal masses during pregnancy are mature teratomas or dermoids, or possibly corpus luteum cysts. So let's look at appendicitis. One of the difficulties with diagnosing appendicitis during pregnancy is that there is an upward displacement of the appendix by the uterus during pregnancy. So there's confusion of the symptoms with other pregnancy-related issues, such as liver disease. There's an absence or blunting of usual signs or symptoms, and the physiologic leukocytosis of pregnancy can sometimes mask the problems associated with appendicitis. This is the most common surgery during pregnancy. 25% of all non-obstetrical procedures occurring in about as many as 1 in 500 pregnancies. Appendicitis actually occurs during pregnancy at the same rate in pregnant and non-pregnant patients, with the risk of appendicitis peaking in the second trimester. However, it's more likely to progress to perforation. In fact, there's a 43% chance in pregnancy versus about 15% chance of perforation during patients who are not pregnant. And this is because of the delay in diagnosis and the reluctance to operate, giving rise to more severe disease and more advanced progression of that disease, resulting in a maternal mortality of 0.4% due to delay in perforation and ensuing peritonitis. The fetal mortality increases to 11% in the instance of peritonitis with a ruptured appendix. So preterm delivery and hemorrhage risk increases also with peritonitis. So these are all arguments for a rapid diagnosis and a rapid intervention with surgical appendectomy. If you look at appendectomy, certainly you want to consider patient selection, positioning, the port placements, insufflation pressures that we all talked about just a few minutes ago. Some of these things must be modified because of the gravid uterus. With respect to anesthesia, intraoperative CO2 monitoring is critical to maintain the normal CO2 of pregnancy. Also, you want to consider venous thromboembolic prophylaxis because you already have an increased risk during pregnancy, and now when you're adding pelvic surgery, you increase the risk even more. Fetal heart rate monitoring should occur before and after surgery, but there's no indication that you need to continue that during surgical intervention. Obstetric consultation can be obtained either pre or after operation based on the acuteness of the patient's disease. There is no evidence that you need tocolysis during laparoscopic surgery during pregnancy. Next, let's look at cholecystitis. This is the second most common surgery during pregnancy, about 1 in 2,000 pregnancies. And there's an increased risk if there's a history of biliary colic prior to pregnancy. And it's actually more common in the early postpartum interval than it is during pregnancy per se. About 10 or 15% of the population has gallstones, and this is about 3.5% of pregnant women. 10 to 20% will develop symptomatic disease, and almost half of these patients will require surgery during pregnancy. Pregnancy-induced gallbladder stasis increases bile acid accumulation, and that alters the bile salt kinetics and enterohepatic circulation, which promotes the formation of biliary sludge and cholesterol gallstones. Therefore, the incidence is slightly increased. Symptoms are the same as in non-pregnant patients, including mid-epigastric and right upper quadrant pain, nausea and vomiting, fatty food intolerance, and abdominal bloating. Murphy's sign is less common in pregnant patients because it can be masked by the gravid uterus, and it's easy to confuse cholecystitis with appendicitis due to the displacement of the appendix by the pregnant uterus. Ultrasound is the diagnostic modality of choice, and medical management is successful in up to 70% of cases, but about 30% are going to require surgical intervention. Surgery can be performed during any trimester when it is indicated, but it is most commonly performed in the second trimester. There are some recent data to show that if cholecystectomy is performed in the third trimester, this increases adverse outcomes, and the patient is more likely to convert to be an inpatient and is more likely to convert from a laparoscopy to a laparotomy. The increased risk, there is an increased risk of preterm delivery, about twofold in patients who are operated on during the third trimester for cholecystitis, and an increased risk of readmission for complications. Now, when we look at adnexal masses, these are actually much more common in pregnancy, but require operation much less. The incidence of adnexal masses during pregnancy is about 2%, and most of these are functional cysts that resolve spontaneously. but about 30% of those are asymptomatic incidental findings during pregnancy, particularly dermoids. About 60% of adnexal masses will present with pelvic pain, representing either adnexal torsion or rupture of the mass or intracystic hemorrhage. Removal of the masses might be warranted, particularly in patients with persisting masses at 16 weeks or masses that are greater than 6 centimeters in diameter, because they're more likely to become symptomatic. If patients are symptomatic or there's concern for torsion or there's suspicion for malignancy, these would be indications for surgical intervention during pregnancy. But often close observation is acceptable if the patients are not symptomatic and ultrasound findings are not concerning for malignancy and tumor markers are normal. In a study of about 4.5 million patients, laparotomy versus laparoscopy yield exactly equivalent maternal and fetal outcomes. There is no increased risk by using a laparoscopic approach for removing adnexal masses when indicated. An ACOG practice bulletin of evaluation and management of adnexal masses indicates that the evaluation in pregnant patients should be similar to that in premenopausal non-pregnant patients, including abdominal or transvaginal ultrasonography and MRI when necessary. You have to recall that CA-125 actually peaks during the first trimester, so this is not necessarily of great value in trying to determine the risk of malignancy. There are some other things that we can do, and we'll talk about those in just a minute with respect to ultrasound. The excision of persistent masses during pregnancy is safe and actually not uncommon. The intent is to prevent emergent intervention for torsion or rupture. The second trimester is actually the optimal time due to the relative quiescence of the uterus and continued access to the mass before the uterus gets much larger during the third trimester. There are multiple reports supportive of expected management. In fact, 51 to 70% of adnexal masses are functional cysts and actually will resolve spontaneously during pregnancy. And predictors of persistence, though, are size of the mass, greater than 5 centimeters, and complex cystic morphology. Low risk for both malignancy and acute complications are actually characteristic of most adnexal masses. The actual occurrence of complications is less than 2%, and you should always consider patients with adnexal mass for conservative management or expective management rather than operative management. Malignancies are very rare during pregnancy and should not be suspected unless there are extremely elevated tumor markers, the presence of abdominal ascites, nodular or fixed pelvic masses, or the evidence of distant metastases by imaging, or if other imaging findings, particularly Doppler, suggest malignancy. There certainly is a role for tumor markers in trying to determine whether malignancy is of increased risk, but remember, of course, that CA-125 is already elevated during pregnancy. The most common modality for evaluation of cystic masses for the potential for malignancy is with ultrasound or magnetic resonance. There's a new system for evaluating ovary cysts called the ORAD system, which is a stratification system from the American Radiologic Society. And a number of different features of the ovary are taken into consideration. One is that the lesion is not consistent with a functional cyst or normal physiology. Looking at whether it's unilocular or multilocular or whether there's a solid component. Certainly the size of the mass is important and whether it's solid or solid appearing. Cystic lesions that are smooth or whether there are papillary projections, regular or not, anechoic or hyperechoic fluid, and general extra-ovarian findings such as ascites or cul-de-sac fluid or peritoneal thickening or nodularity. But the most important is the vascularity by Doppler. And if you look at the scheme that has been proposed by the American Radiologic Society, there are a variety of different characteristics of vascular flow that are associated with increasing risk of this being a malignant tumor rather than a benign cyst. If you look at this ORAD system, you can see that it receives a grade based on all of these various characteristics we've just discussed, all the way from 0 to 5. And these are very characteristic. You can see here examples of normal follicles and of typical corpus luteum follicles or corpus luteum cysts in the ovary that are very benign and not concerning for malignancy. Again, the most important feature is the vascular flow. If you look at the categories of risk stratification using the ORADS system, this goes from an incomplete evaluation or a score of 0 up to high risk for malignancy, and gives recommendations on who should be following these patients and how they should be followed or what interventions should be necessary. I've listed here the reference for this manuscript that describes this in detail, and I strongly encourage you to get that manuscript and become familiar with it. It's very helpful. Benign and malignant ovarian masses in pregnancy, in a study of almost 5 million patients, there was a very low incidence of ovarian masses, less than 0.2% of those pregnant patients. In those patients with ovarian cysts or ovarian masses, there were only 87 ovarian cancers. That's less than 1% of over 9,000 cysts, or less than 0.1% of per 1,000 deliveries. In these, the vast majority of these were germ cell tumors, and the cause-specific maternal mortality is actually very, very low, as most of them are detected at a very early stage. In this study, there were no adverse neonatal outcomes. There was an increase in the risk of C-sections and longer hospital stays, and an increased risk of hysterectomy because of concern for malignancy. So in summary, the incidence of adnexal masses in pregnancy is actually very low, only 1 to 2%, and in fact, most of these are functional cysts. Ultrasound or MRI imaging is the modality of choice in order to diagnose or characterize these cysts during pregnancy. The majority of the cysts are functional and resolve spontaneously, and this applies to about 70% of cysts. Persistent cysts are most likely dermoids or cystadenomas, which is a similar incidence as non-pregnant patients. Ovarian cancer in pregnancy is very rare, only 2 or 3% of cystic masses. The most common type are early-stage germ cell tumors. You can usually delay intervention until after pregnancy, but if the cysts are persistent, symptomatic, there's concern for torsion, or there's a higher suspicion for malignancy, you need to go ahead and intervene during pregnancy, as there's no or very little increased risk to the pregnancy per se. The approach to your intervention depends on the size of the mass, the size of the uterus, and the skill of the surgeon. The optimum time to operate during pregnancy is during the second trimester, but certainly you don't want to delay operations should it be necessary, regardless of when during the pregnancy that occurs. So if you look at the general recommendations of laparoscopy during surgery, the American College of Obstetricians and Gynecologists and the American Society or GI endoscopic surgeons make certain recommendations, and that is diagnostic laparoscopy is safe and effective in the workup and the treatment of acute abdominal processes during pregnancy. Laparoscopic treatment of acute abdominal disease has the same indications and benefits over laparotomy in the pregnant and non-pregnant patient. Laparoscopy can safely be performed during any trimester of pregnancy, but the second trimester is optimal. The initial abdominal access can safely be performed with any technique by experienced surgeons, but we typically use the left upper quadrant as our entry point. Intraoperative and postoperative compression devices and early postoperative ambulation are recommended for prophylaxis in DVT in the pregnant patients. Gravid patients in the second and third trimester should be placed in the left lateral decubitus position to minimize compression of the vena cava. CO2 insufflation of a little bit lower intra-abdominal pressure should be used to adjust for the patient's physiology. Fetal heart rate monitoring is generally done pre and post-operatively, but there's no indication to monitor fetal heart rate during surgery. And tocolytics are not typically used prophylactically and should be considered perioperatively if there are signs of preterm labor. Steroids should be administered prior to pregnancy if the fetus is viable, just in case a emergent cesarean section is necessary, and be sure to consent all patients for cesarean section as indicated. So I hope these data will make you feel more comfortable being aggressive in the evaluation and appropriate intervention in patients during their pregnancy should they have problems that arise that require surgical intervention. Thank you very much for your attention, and I certainly appreciate your being with us today.
Hello, Ted. How are you?
Doing wonderful, thank you. It's great to be with you electronically.
I'm Charles. Thank you so much for your excellent speech. Now, open for free discussion. May I mention again, anyone want to make comment or question? Please switch on your speaker in your sides, and also specify yourself. Now, open for discussion from the floor. Hello, Ted. May I give a question? Regarding the operation for Adnexal Masses, because of bigger uterus, will you tell more how to choose the trocar sites?
Well, that's the most important question. Usually when we're concerned about a mass or we're concerned about an enlarged uterus, we will use the entry in the costal margin in the left upper abdomen. However, in patients who've had prior bariatric surgery, this is not so much a safe place either. So what we will usually do is we will modify our technique that we use visual entry, where we actually watch the trocar go in through the layers of the abdomen so we can stop just when it enters the abdomen before we hit the uterus.
Sorry, will you start from the right side or left side?
We usually start from the left side.
Left side, okay. Any more question or comment from the floor?
Thanks for Professor Anderson. I'm Dr. Chen. I'm interested in your talk about appendicitis. And in our hospital, some physicians would suggest appendicitis to receive medical treatment before surgery. And how about your opinion? The appendicitis in pregnancy, should we go through to the laparoscopy surgery, or we can do the medical treatment with antibiotics conservatively?
I think the data would show, because the consequences of a ruptured appendix are so high for maternal mortality and for fetal mortality, up to 11%, that we should be aggressive with surgical treatment of appendicitis in pregnancy rather than medical treatment.
It can be difficult to make decision because once appendix rupture may cause a lot of complication, including preterm birth. Any more question? Yeah.
Yes.
Any more question?
Thank you.
Any more question or comment? May I give you a short question? You have mentioned about the application of steroid for preterm birth. Regarding the infective surgical condition, saying appendicitis or cholecystitis, it may have a serious infection, do you still consider the application of a steroid for preterm birth after operation? I mean, routinely.
This is always a concern, and we involve our high-risk pregnancy colleagues in making that decision. When we try to weigh the benefit or the risk of an overwhelming infection versus the risk of an infected fetus, we tell our neonatal colleagues the only thing worse than having a preterm delivery is having an infected preterm delivery. So we're very cautious about trying to get antibiotics on board. We're cautious about trying to make an early diagnosis and an early treatment. But I think there is still some clear evidence that corticosteroids are beneficial. So we tend to be a little bit more aggressive in using the corticosteroids despite an infection.
Thank you, Ted. Doing good thing always short. Let's move to the third speaker. Thank you so much, Ted.
Thank you very much for having me.
My great honor to introduce the Professor Evans. Professor Evans got his medical doctor degree in the State University of New York. And he is the professor of obstetrics and gynecology in Mount Sinai School of Medicine. She also is the president of Fetal Medicine Foundation of America, USA, and director of comprehensive genetics of Mount Sinai Hospital. And she's the president of the also, and he is the many famous journal, the editorial boards, including the American Journal of Medical Genetics and Journal of Society for Gynecology Investigation and Reproductive Science. And also now he is the editorial board of Prenatal Diagnosis and Journal of Reproductive Medicine and Journal of Maternal Fetal Neonatal Medicine. Now we welcome his talk about NIPT, the right answer to the wrong question.
Everybody, it's my pleasure to be with you at this conference. I have been to Taiwan once before, invited about 7 years ago by my good friend Ming Chen, who, like myself, is an obstetrician and also a medical geneticist. Actually, this is from his conference, to talk to you on NIPT, its uses and limitations. Let me share my screen. The whole world is now beginning to come out of the lockdown from the pandemic of a couple of years ago. This picture is of Times Square during the pandemic that looks virtually empty. By the way, for those of you who know, this is where the ball drops every New Year's Eve. Now we are seeing a much more re-engagement with a lot of crowds outside with presumably some safety. Overall, worldwide, there are about 144 million births per year. In the United States, we have 4 million. Taiwan has about 165,000. India has about 27 million. Overall, there are over 8 million babies a year born with birth defects. Several 100,000 of these start with post-conception teratogenesis, such as alcohol, rubella, syphilis, and iodine deficiency is very common in central China. Over 3 million babies a year die under age 5, and also 3 million babies are disabled for life. The incidence of congenital heart disease is actually almost 5 times as great as Down syndrome, which is the focus of most prenatal diagnosis programs. Neural tube defects and hemoglobinopathies are also as much as 50% greater than Downs, yet the focus has been on Downs, Downs, and Downs. The New York Times author, Tom Friedman, wrote in a column about 5 years ago about a climate of technology where we analyze, see patterns that were always there but hidden, optimize, for example, telling a plane at which altitude to fly to get the best fuel efficiency, prophesize to tell you when your elevator is about to break before it actually breaks, customize, which is to tailor any product or service for you alone, i.e. personalized medicine, and digitize and automate just about everything that possibly can. I would personally add to that the ethical principle of proportionality, which is trying to get the most benefit for the least harm, and balancing with common sense, maximizing efficiency without losing the personal touch required for optimal care. Now, having a baby in 2022, couples need to know that 2 to 3% of all babies are born with some sort of serious problem. If you include the minor things, it can be up to 5 or 6%. We can divide the major ones into 3 fundamental genetic groups. First are the Mendelian disorders, like if you're African American, we talk about sickle cell. Ashkenazi Jewish, we talk about Tay-Sachs disease. These are not age dependent. Multifactorial disorders, which include some of the spinal defects, cardiac defects, and some of the psychiatric defects, also again not age dependent, and there is no yes/no switch to those disorders. And finally, the chromosomal disorders such as Down syndrome, which are related to advanced maternal age, but more babies with abnormalities are actually born to younger women because so many more younger women are having babies than older women. And the purpose of genetic screening and testing is to provide information. What the couples choose to do with that information, at least in most Western cultures, is their decision, not the government's, not the doctors. Now, over the last 25 years, we've seen several simultaneous trends in prenatal diagnosis and fetal screening. Number one, increasing expertise in ultrasound and visualization, increasing safety of diagnostic procedures, an increasing number of genetic screening and testing possibilities, a shift coming from cytogenetic techniques to molecular ones, but there continues to be a vast underappreciation of the residual risk of still having a baby with a problem despite a normal screening test. Now, the pendulum between screening and testing has gone back and forth now for 60 years. In the 60s, the only screen we had for Down syndrome was advanced maternal age by asking the patient, how old are you? And if she told us she was 35 and 2 months, you said, oh my, she's high risk. But if she said she was 34 years and 10 months, that was low risk. Now, obviously, this is nonsense. So we went from screening to procedures with amnios, back to MSAFP, back to CVS, to enhanced screening with ultrasound, nuclear translucency, biochemistry, genetic scans, and now cell-free DNA, versus procedures that include molecular microarrays, SNPs, etc., to give us definitive answers. Now, there's the old Confucius curse that says, may you live in interesting times. These major leaps in technology are allowing us, but I would actually say forcing us, to completely reframe our approach to screening and diagnosis. Now, if you remember one thing only from today's lecture, please let it be that prenatal diagnosis and screening is not just about Down syndrome. We now have to consider all sources of structural and neurologic impairment. And in fact, on a parallel track, we now can also add certain maternal health situations such as pre-eclampsia. And just to mention this for a minute, it behaves like a multifactorial genetic disorder. The incidence of appearance of threshold can be modified by various risk factors, such as having twins, whether you're short, etc. And by screening in the first trimester at the same time as the nuchal translucency, we can identify almost 90% of the very bad early onset cases, which are the ones that cause us a problem today, and then do something about it by the use of low-dose aspirin. This has been very effective, and it is a game changer as far as I'm concerned in the approach to overall screening. Now, over the course of my career, dating back to the late 70s, the primary focus of prenatal genetics in the 70s and 80s was doing procedures, getting a specimen, whether they were being done relatively safely, they were being done blindly often. In the 80s and 90s, ultrasound became developed, and we could often see a lot of things. In the 90s and 2000s, the laboratory got much more sophisticated with the material that we gave them. The problem we're seeing now is the laboratory people saying, well, who needs the doctor? We'll just do this without them. And the problem is many of these companies developing these techniques are not run by physicians, not headed by physicians, and they're headed by engineers who also were not were not trained in the ethics of medicine and taking care of the patients first, not their profits. Now, over the course of these decades, we've seen, for example, amniocentesis was experimental in the 60s, has been routine ever since. CVS was experimental in the 80s, has been around since then. Nuchal translucency came in the 90s, experimental then routine. Fetal cells came, went, are now possibly making a comeback. Free RNA was tried in the 2000s and now maybe is coming back, but it's very labile. The cell-free DNA was experimental, now routine. In fact, is becoming very, very prominent. The microarray was developed at the same time as CVS, had a longer experimental gestational phase, and is now available to us. And where we're going are microdeletions, whether they be from the microarray or non-invasively. We're switching towards whole exome sequencing and ultimately whole genome sequencing to get better definitive answers. Now, I am both a clinician and a relator of laboratory disorders. Clinicians do not care how you did a test. All we want to know is, did you get the answer right or not? And when the lab gets it wrong, will the lab stand behind the doctor in the management of these cases, including medical legal risks? And what is the cost benefit of increasing laboratory testing? Now, there are two different types of tests. A diagnostic test is meant to give us a definitive answer. They're commonly expensive. They may have risks, and therefore they're only done on so-called at-risk patients, whatever we decide that means. On the other hand, screening tests are meant for everybody. They only adjust odds. They do not give us a definitive answer. And over the years, the performance statistics of these have generally improved. Now, going back to the 70s and 80s, we've seen parallel developments in improvements in both Mendelian and chromosome analysis. For Mendelian, we started out with a small number of disorders with simple genetics, such as sickle cell, in which everybody on the planet has the same one base pair change. For chromosomal disorders, we started with whole chromosomes. As a medical student, I spent some time in the lab of Dr. Chio at the NIH, who is the investigator who said, excuse me, there aren't 48 chromosomes, there are 46. We then began expanding our Mendelian panels to include things like cystic fibrosis. And the question was, how high an incidence does it have to be to test for? We had increasing resolution on the cytogenetic side, developing FISH, QFPCR, and other for deletions and additions. We then went to a period where we were expansive by genotype for Mendelian and expansive by microarray. And where we're going is moving everything back into sequencing, which not only will give us better answers, but also will make the technology basically the same to make it better, cheaper, and easier to run. The question, of course, is how much is it reasonable to spend on all of this, and who's spending it? If it's you don't care if a test costs $1 million and somebody else is paying for it. If you're the health minister, you very much care how much does it cost versus how much are we saving by doing these prenatal screenings and diagnosis. Now, for Mendelian disorders, we know that every one of us carries numerous genes that, if homozygous, i.e. the baby gets both copies, that are lethal or severely disabling. And we can now find out the carrier status of literally hundreds of these disorders before the couples had the tragedy of an affected baby. The incidence of these problems is as high or higher than Down syndrome. And the concept of ethnic stereotyping, oh, you're Jewish, we worry about Tay-Sachs disease, is basically disappearing. For example, we know that Down syndrome occurs in about 1 in 800 births. Open neural tube defects varies by ethnic group around the world, but in the US is about 1 in 1,000. Cystic fibrosis is about 1 in 3,500, yet the odds of having a baby with a Mendelian disorder can be as high as 1 in 300. And again, these are not age dependent. Here's an example of a tragic case I saw several years ago where a Jewish couple had the Ashkenazi Jewish screening. One of the disorders tested for is Mendelian myopathy, and they were told you're both not carriers, the residual risk is 1 in 10,000 or less. Well, they had a baby with Mendelian myopathy. The pediatricians then ordered a sequencing screening test for Mendelian myopathy carrier status, and guess what? Of course, they both were carriers. So the technology is going from there to even doing better. Now, when do we use stuff? The standard of care has two different meanings. One is it's acceptable, and one that it's required. Now, we will get to the point where there'll be no excuse for a laboratory using a modern technique and not just a acceptable one. Now, the race to add more and more disorders is at very glance very appealing, but the chance of finding the 500th disorder in a couple that's non-consanguineous is so low, one can reasonably ask the question, is it worth doing except in consanguinity? And there has to be a sweet spot that each country has to find for itself based upon its ethnic backgrounds, et cetera. Now, cell-free DNA, generally known as NIPT, but more realistically, non-invasive prenatal screening, came on the market in the US in 2012. There have been very aggressive marketing campaigns. Frankly, the biggest driver of the uptake of NIPT is the parents want to know, are they having a boy or a girl? We see sales forces, not the lab literature per se, they're trying to be squeaky clean, saying that NIPT is a replacement for diagnostic procedures because it finds the same things and eliminates those dangerous procedures that I've done 70,000 of with an incredibly low risk rate. The scope was originally focused on the high-risk population, but of course it quickly expanded to the low-risk population because that's where the money is. There are 20 times more patients who are low risk than high risk. Over the past decade, the use of NIPT in the United States and around the world has skyrocketed with a 30 to 50% drop in diagnostic procedures. At the same time as NIPT was being developed, microarrays were being developed, following the more traditional academic approaches, and produced a number of referee papers before they went on the market. And a big National Institute of Child Health and Human Development collaborative trial paved the way for it coming into practice in around 2012. Now, the one thing that all screening tests evolution do have in common is over the decades, they have had better sensitivities and lower false positive rates. And this has been from how old are you to low AFP to double, triple, quad, NT, combined sequential, and now cell-free DNA. This is the way things are moving, and that is good. However, we have some semantic test issues. If a test gives you a 100% accurate answer if you get a result, but you only get a result 90% of the time, hypothetically, is that a 100% test or is that a 90% test? Well, the lab people say, well, it's a 100% test because when we could get you an answer, we were right. As a clinician, I say, no, if you only give me an answer 90% of the time I give you a specimen, I have 10% of my patients very upset that they've wasted time, wasted money to be back where they started. Now, there's some obvious reasons why we may not get an answer. Cell-free TNA is only reasonable at about 10 weeks or more. That's getting better, but still it's a major problem. But very importantly, in patients who are overweight, the failure rate can be as much as 50%. And critically, when there is an abnormal fetus, the chance of failure is much higher. In fact, the failure of a test not at just 6 weeks of gestational age is in and of itself a reason to do a diagnostic test, not repeat the screening test. Now, many of the labs will tell you, oh, we only have a handful of cases missed every year. And in fact, that is just simply not true. The failure rate varies in the last several years from 1% up to 6 or 7%, and they're just not being honest with you. Now, for the past 20 years, we've been doing first trimester combined screening, and the lab may tell you your patient's risk of having a baby with Down syndrome is 1 in 9,326, whatever. The fact is that if you did a CVS or an amnio with a karyotype, the lowest chance of finding an abnormality is really about 1 in 500. If you do a microarray on the CVS or amnio specimen, which I'll show you the data later, the chance of an abnormality is actually 1 in 100, regardless of how old the patient is. And that's comparable to the risk of a 38-year-old. So as far as I'm concerned, everybody is now high risk because they're greater than the risk of the 35-year-old, which was considered the threshold. So I offer CVS and microarrays to everybody who walks in my door. There are only two requirements. They have to be female and they have to be pregnant in order to get this test offered to them. We're also seeing that the financial cost to find a case of Down syndrome by NIPT that you would have missed by nuchal translucency and combined screening was originally close to $3 million. It's much lower now as the tests have gotten better, but it still costs you more. And again, if it's your family, you don't care if somebody else is paying for it. But if you're the health minister of a province, you do have to care about it. Now, a study we did a decade ago on combined screening showed that on 20,000 screened patients, screen positive for Down syndrome was in 5.7%. Of those patients who then had CVS to follow it up, the abnormality rate for them was 4% of the 5.7%. However, only 59% of those abnormalities were Down syndrome. 40% were something else. And even if you throw in the 13s or 18s, 1/4 of the abnormalities were not something you were screening for. And so therefore, if you do, and if you have an abnormality, you must follow this up. So the question is, what are we looking for? You know, I have patients in my office every day saying, "Doctor, I'm concerned about having a baby with Down syndrome." What they really mean is they're concerned about having a baby with a serious problem, and Downs is the name they happen to know. When we were children, at least in America, your mother might have sent you to the grocery store, "Go buy me some Jell-O," the gelatin. You didn't know that it was a brand name. You thought it was the product. Okay? So what we have is patients being given the right answer about Down syndrome, but it's not the question they're actually asking. So the real playing field, not to use our quote alternative facts that we see in America, is cell-free fetal DNA is a screening test. Fetal cells in maternal blood or a cervical swab might become a diagnostic test. And for now, CVS and amnio specimens can give you that diagnostic test. So the reality is we're debating NIPS versus microarrays for the best way to manage this situation. As I said, the definition of high risk has evolved. In the 70s, it was age 40, then 35, now 35. With biochemical screening, high risk became the risk of having a child with Down syndrome comparable to a 35-year-old, which is, there are 4 different numbers that apply to that. It's 1 in 190 at birth for having a karyotypic chromosome abnormality. Only half of those are Down syndrome. In the mid-trimester, the chance of carrying a baby with Down syndrome is 1 in 270s. The reality is, with the newer methods, the minimal risk for a serious problem for everyone is about 1 in 100 with a clarification of the VOUSs. Reality has also set in. People are being told, "Oh, there's a 99% chance we can find your baby with Down syndrome." Trouble is, not every test works as well as Downs. A few years ago, I had a patient come in being freaked out by her doctor who said, "You have a baby with Turner syndrome." And yes, the sensitivity of finding Turner syndrome is in fact 99% for Downs, but the true positive rate, the chance that she is carrying a baby with Down syndrome, was only 38%. And in fact, this case turned out to be normal. As we now expand into the microdeletions, most commonly DeGeorge syndrome, the positive predictive value is in the single digits. It's getting better for DeGeorge, but for the other ones like Prader-Willi, Angelman, 1p36, it's less than 10%. It's like a 2.5 millimeter NT. And there's a obfuscation of what the performance metrics are for the particular disorders, thinking everything is Down syndrome. Now, the American College of OBGYN, which is usually the last kid on the block to recommend anything, is recommending against the NIPT microduplication and deletion screening. At this point, I actually agree with them. The performance metrics are terrible. It's giving patients a false sense of security and missing 99% of what you could have found. Now, that requires a CVS or an amniocentesis. There have been multiple debates in the literature as to what the risks really are. The numbers are quoted between 1 to 2% down to 0.1%, and the truth is somewhere in the middle. There are people who say, I've never had a complication from an amnio, to which I say is, well, maybe you don't do many, you're not looking, or you're simply not telling the truth. There is a measurable complication rate to everything, including walking across the street to your car. There have been a number of large studies over the last 15 years that have looked at this. The first one was a wonderful meta-analysis by my friend Zarko Alfirovic that showed that within 14 days of an amniocentesis, the total loss rate was about 0.6%, by 24 weeks 0.9 and 1.9 by birth. For CVSs done a month earlier with a higher background loss rate, the total loss rates were 0.7, 1, and 2. Basically, they were exactly the same. In Denmark, where they had a very large nuchal translucency program begin in the 90s, and therefore there were 3 times as many CVSs as amniocenteses done, guess what? CVS was not increased risk. In fact, amnios later had a higher rate of stillbirth than did CVSs. Meta-analysis coming out of London by Dr. Okekalar showed no differences in total loss rates between patients having CVS, having amniocentesis, and having no procedure whatsoever. Now, in the US, when CVS began in the 80s, under the Reagan administration that was very opposed to abortion, there were lots of people not wanting this technology to get out there. And so there were severe restrictions on the availability of the CVS catheter. I was one of only 15 centers that had such approval for the testing. Well, there are many doctors out there who experienced an amniocentesis who are very annoyed about being, quote, locked out of the new technology. He said, well, I can do an early amnio. The problem is, what's the definition of an early amnio? Now, to me, an early amnio is a case done before 9 o'clock, and a very early amnio is done before 7:30. The reality is you have to do it by the gestational age, and in fact, at 11, 12, 13, 14 weeks, CVS is actually a much safer test than amniocentesis. There are also laboratory advantages of CVS. We get much more material from the tiniest solid tissue specimen than we do from 30 cc's of amniotic fluid, which allows us to do the molecular techniques much easier and faster. And also, I do a lot of multiple pregnancies. This is a triplet pregnancy where fetus A has a low anterior placenta. I would do this one transcervically. B has an anterior fundal placenta. I would do this one abdominally. And you can see my catheter coming in posteriorly into fetus A. And I do CVSs before all the reductions so we know what we're dealing with. This is a patient I saw. Actually, husband was a physician, where had I done the reduction based upon ultrasound, I would have reduced this one, except CVS showed that that one actually had Down syndrome. We also do Mendelian disorders, carrier couples, where we can get the diagnosis of fetal disorder before doing the fetal reduction. Now, the real game changer has been the development of the microarray. The most common one of which we think about is the George syndrome. Now, obstetricians have been taught to think about the George syndrome being associated with cardiac abnormalities. In fact, the psychiatry litter is replete of cases of adults with the George syndrome, of whom 75% are almost psychotic. It's really amazing the differences. But the George syndrome, which has a deletion of about 3.5 megabases, Miller-Dieker, Prader-Willi, Smith-Magenis, all have gains or losses of material too small to be seen by the karyotype, and therefore we needed a better test. The way I explain this to people is if you're watching an old style television set like we used 20 years ago, the number of pixels, the number of dots in the picture are about 500,000. You watch the high def sets in routine use today, they have 2 million. It's that 4-fold difference in the data density, how many dots per square inch, that give us the better picture. The difference between the karyotype and the microarray is a 30-fold increase. Okay, why do we care? We know that 1% of all children develop a neurologic handicap, developmental delay, from one of about 100 different genetic disorders. The microarray can find about 40% of them, and these are things that do not have ultrasound findings. We know that about 1% of babies develop autism. We can find about 20% of them. But the important number is patients who have nothing else going on. The history is normal, the ultrasound is normal, even the karyotype is normal. we're finding a 1% abnormal CNV rate, and this is not age dependent. It's 1% if you're 22 and 1% if you're 42. Then people say, well, why can't you find this on the NIPT? I say, well, think of Down syndrome as an AM radio station. We've got great AM radios. We can find virtually all of them. But think of these other disorders as FM stations or shortwave stations. Unless you have the proper radio, you're never going to find them. And eventually we'll have it, but we don't have it now and won't have it for several years. Now, so particularly for younger women, for whom the incidence of an abnormal microarray is literally 10 times more than finding an abnormality on NIPT, concentrating on Down syndrome and ignoring is like ignoring the 500-pound gorilla in the middle of the room for the mosquito in the corner, which, unless the mosquito has Zika, from a public health perspective, is nowhere near as important. Impact upon practice. The large cytogenetic labs have reported over the last decade drops of 30 to 50% or more of CVS and amnios. Primary OBs are no longer sending patients to the MFM genetic centers for counseling and testing. They're relying upon the NIPS. And often the first subspecialist encounter is for the 20-week ultrasound. My friend John Williams, who's the Los Angeles CVS guy, reported several years ago that his referrals for genetic counseling had declined 28%. But his referrals for counseling for conditions that had nothing to do with NIPT were down about 20%. And as a result, patients are actually getting worse care than they did before. I have published a few papers yelling and screaming about the problems here, and basically saying that everybody should be offered a diagnostic procedure. We've also shown that the price in financial terms of not having diagnosis is very high. And we also published on the epidemic of abnormalities missed because of relying upon NIPT. Now we looked at, now we're putting on our finance minister's hat. We looked at the cost of taking care of babies for whom prenatal diagnosis could be found with proper screening and diagnosis. And again, we're not making any value judgments here. We never tell a patient what she should do with such a diagnosis. But the reality is, for many of these common ones, the cost of taking care of these babies is well over $1 million above routine care. Okay? So these are not cheap things to do. Now, in the US, from a societal point of view, there are about 6,000 Down syndrome babies a year born. They cost about $1 million per year over and above. That's costing us $6 billion a year. There are about 8,000 cerebral palsy severe cases that also cost us $1 million. This number is actually much higher than that. That turns into $8 billion very conservatively. There are still 40,000 new HIV cases a year. I find that remarkable. They cost about $100,000 a year. That's $16 billion. In the US, we have close to 40,000 auto fatalities a year. We're doing everything possible to decrease this. We have 35,000 gunshot wounds a year. We're doing everything possible, unfortunately, to increase this with our politics. The number of missed CNVs is between 35 and 40,000. Even if we cost those out at $500,000 a year, 1/3 of what I modeled, that's still costing us 3 times what we're paying for the care of Down syndrome babies. So this is a serious issue. So in conclusion, the focus on Down syndrome risk alone significantly understates the total observed risks. NIPT is an excellent screening for Downs, but it's too limited and too expensive as far as I'm concerned for universal screening. Patients are being falsely reassured who might otherwise forego having a diagnostic test. Eliminating the nuchal, because the NIPT can find everything, is a false economy. Too many other problems, gestational age accuracy, zygosity and multiples are being missed. Eventually, deep sequencing NIPT will get there, but we're nowhere near there now. Never before have we seen one technology essentially replace another that both simultaneously lowers the detection rate and costs more. There are risks to the provider, at least in cultures where there's liability exposure. The technology has never been greater. Confusion is rampant for patients and physicians. The risk to the provider for MISC abnormalities has never been greater. Documentation in the chart of the explanation to the patient has never been more important. And therefore, when possible, independent genetic counseling with documentation is best protection for both the patient and the provider. Now, the future is sequencing the genome. The only question is going to be whether it's going to be on embryos, villi, amniotic fluid, or non-invasively. And in my opinion, as long as there is a gap between what can be found by NIPT and diagnostic procedures, those procedures must be offered to everyone, whether they choose to have it or not. I'd like to thank you very much for the privilege of addressing the Taiwan Association of OBGYN, and we'll now move to the live session where I can answer some questions. Thank you very much.
Thank you for Professor Evans for your excellent lectures about the new information, very advanced knowledge in the prenatal diagnosis. Now we are open for the discussion. And is any question from the audience? Dr. Dai, you have a question?
Hello, Professor Evans. Do you have any comments about if we do the whole exome sequence to detect the copy number variant loss instead of microarray?
That the technology will continue to advance and that we will move from, first we had routine karyotypes, then we're moving towards routine microarray. Next will be routine whole exome sequencing, and eventually there'll be some form of whole genome sequencing. With each new advance, we're able to find an increasing percentage of anomalies. My goal, which is not necessarily the way everybody thinks about it, is to put patients in control of their own destiny as much as possible. To do that, they have to have information. And couples will decide for themselves how much information they want. But certainly for the top 25% of patients who are interested in this, the more data we can get them reliably, the better off everybody will be and the happier they'll be. So it's coming.
Evans, and is any other question? Professor Evans, and now in Taiwan, we have started the extended carrier screening after the patient get pregnancy in the early pregnancy to detect the carrier stage. Would you suggest to do the carrier screening before the patient, the infertile patients, before the receiving the in vitro fertilization?
Absolutely. 30 years ago, 90% of the time, I was doing a CVS for a molecular disorder like sickle cell, thalassemia, etc. It was because the couples already had an affected child at home. Now, 90% of the time, we're learning carrier status before the tragedy of having an affected baby. And there's absolutely no reason that we shouldn't extend this to patients who are having IVF or are getting pregnant the old-fashioned way. The more we know, the sooner, the better care we can give. Now, I remember, back in the 80s, where the best you could do is, if the patient were African, you do sickle cell. If she were Jewish, Tay-Sachs disease. And if she were Asian, you did thalassemia, mostly alpha thalassemia. Then we went from 1 disorder to 3 to 10 to 20. And now we're close to up to 500 disorders that some labs are routinely testing. And for women, up until about their 35, the chance of having a baby with a Mendelian disorder is considerably higher than having a baby with Down syndrome. So again, I think we have to take an expansive view of all causes of neurologic impairment and abnormal development, and that which we can screen for beforehand and prevent, preferably, for couples who are at high risk, certainly IVF and PGT is a very good way of doing it. Although, let me add, it still must be confirmed by CVS or amnio. There's still about a 1% mistake in PGT results. But absolutely, the more information we have going in, the less chance of tragedies coming out the other end.
Events, yeah, we will do PGD, we will do the confirmation test by the CVS of the amniocentesis. Is there any question from the audience? Because the time is limited, so we thank Professor Evans give us very innovative talks. Thanks very much. And then we close this section.
Thank you, Mark.
Thank you. My pleasure.